Good evening. Are my slides visible? Can somebody volunteer? Are my slides visible?
Yes, sir.
Yes, sir.
Yes, sir. So thank you, Dr. Rahul, thank you, Dr. Vivek, and thank you, Mark, for the kind invitation. The topic that I'll be discussing in the next 15 minutes is in the era of immuno-oncology, what is the role or where does anti-EGFR, the purpose of it is cetuximab in advanced head and neck cancer, where does it stand in 2022? Now, yeah, so most everyone us will agree that the most important thing in the treatment of head and neck cancer, or what is the best sequence that gives you the best survival. You have two active agents apart from the normal chemotherapy, which is anti-EGFR and immuno-oncology. How do you place them such that at the end of the day, you get the best survival? So one of the gist of my presentation is to look into it with the impressive data that this drug has. So when we talk about our Globocon data 2020, every one of us will agree that overall, the commonest cancer all over the world in terms of head and neck is oral cavity and lip. But when you try to look into Indian things, the percentage of, when you consider all over, when head and neck, the highest percentage is in lip and oral cavity, which is far more than what you get in a Western countries. Is it important? The answer is yes, because here there is a greater role of surgery, the biology is slightly different, and the drugs works different. So when you talk about all these drugs, IO drugs work, how do they work in head and neck, and cetuximab, how do they work in head and oral cavity is entirely different, and that is something that we need to remember when we discuss about the results of these trials in metastatic head and neck cancer. Now, 60% of the cancers in India in terms of oral cavity is basically commonest, and majority is oral cavity and lip. It is earlier, probably a decade earlier as compared to Western countries, more commoner oral cavity than hypopharynx and other parts. Etiology, non-HPV more commoner in Indian countries and probably more aggressive variant that we get it in India. So probably these are all the things. The site is different, the biology is different, they are younger and they are non-HPV. Now, when we talk about the treatment of relapsed metastatic head and neck cancer, it started with single agent. So it was a single agent methotrexate, single agent platins, single agent 5FU. Then there was a combination between the two, which improved the response rate, but unfortunately the overall survival was between 6 to 8 months. In 2008, for the first time, we had this pivotal study, we continue to use it, and for the first time, this median overall survival exceeded or crossed 10 months, with the absolute quantum of benefit was 2.7 months. Then came a second line immuno-oncology drug. My previous speaker has very clearly listed. What is more important in his presentation is even in second line, this drug works very well, more than around 20% responses, and more importantly, a statistically significant improvement in overall survival as compared to the other arm. So what we know is immuno-oncology works well equally first and second line. In fact, when you look into the first line data of Pembro also, it is not more than 20 to 25% response rate. And then came the two pivotal studies that we all discussed. TP Extreme, a study which replaced 5FU with docetaxel, only 4 cycles with cetuximab followed by cetuximab, and a pivotal Keynote 048 which used pembrolizumab with the same combination followed by pembro maintenance. Probably the crux of my presentation is if you can use your active principles in a proper sequence and all the drugs used, you get the best survival, and we have quite a few data to support what I am telling. So let me discuss my 3 studies that has been given to me. Of course, these are sponsored, but I'll try to pitch in whatever I think is more important. This was a pivotal study 2008 by Vermoken and his team combining cetuximab with the standard of care. So the standard of care we know is cis or carbo with 5FU with cetuxi followed by cetuximab maintenance. And the most important thing we agree is the overall survival. Now, without going into details, what was more important was a 2.7 months absolute improvement and 20% reduction in the risk of death when we give cetuximab. It was tolerable, well maintained, that was it. So for the first time, we had a drug which improved our survival beyond 10.1 months. Now, what is more important, and that is something that we need to understand, is probably when they did a subgroup analysis, oral cavity, which is more commoner in the Indian subcontinent, this quantum of benefit was better as compared to the other arm. So your hazard ratio was 0.42. Try to remember it from 0.80 of the entire population. So probably this combination, every one of us will agree, was better in oral cavity cancer. And this trial shows that the quantum was far better than the entire population. And then came in 2018-19 a study which replaced 5FU with your docetaxel, followed by cetuximab maintenance, TP extreme, so a taxotere-platin extreme versus extreme, a GORTEC group study. Now, there were few things which were peculiar in this study. So a single day treatment, probably this is the way most of us now are treating it. We agree that in the trial it is 5FU, but most of us have replaced 5FU with taxane in the first line, only 4 cycles, and a mandatory GCSF. That was something which helped in reducing the side effects, and the compliance was better. Now, a very good response rate, 57. Try to remember these things. So in a rapidly proliferating disease, a highly aggressive disease, a drug which 6 of the 10 patients will definitely have a response. So 30%, 30% reduction in the disease quantum. Only 8% progressive disease, 57, 8, and the overall survival was 14.5. These are the 3 parameters that we need to remember. 4 cycles, 72% compliance, only 10% delay. So a combination which was tolerable and patients were able to take it. 72% were able to go ahead with the maintenance. Median duration of chemo was 11 and the maintenance of 14. So all in all, a tolerable combination, and majority of us are able to tolerate this combination. More importantly, so the crux is 14.5. A subset of patients who were able to take a IO in the second line. So you are able to use all your active agent, first line cetuximab and second line IO. For these subset of patients, if you see, 21.9 months. So what we have done intelligently is giving all your active agents, and when at the end of the day, 21.9 months in a very big trial like this, you remember this has never been achieved in any of the studies. So what this trial suggested was an active principle in the first line, which gives you the maximum response, equally impressive PFS and OS, and or the overall survival. Do have any other data to support it? Again, a retrospective study of weekly Taxol, Platins, and cetuximab in relapsed metastatic. You can see for 15.2 months is a OS, but more than 50% clinical benefit rate, a very impressive PFS of 7.1. The PFS in IO combination in the first line is 2 to 4 months. Do we have an Indian data? So one of my close friend Chandrakant and his team, this was presented in ESMO 2020, combining your all active. So weekly Pecli, Carbo, Cetuxi, followed by Nivo in the second line. First line, 7 months PFS, 79.7% response rate. And for the subset of patients who were able to take Nivo in the second line, the median overall survival was 20.4 months. So you have 2 consistent studies which are combining all your active agents, and both are more or less the same, nearly 21 months. So that is the crux of my presentation. You need to use your active agent judiciously and in proper sequences to get the maximum response. Now, last 3 to 5 minutes about immuno-oncology. Although my subsequent speaker will be speaking in detail, there are some things that we need to remember when we discuss IO in the first line. So this was a keynote 048, same combination of platins with 5FU with Pembro, followed by Pembro maintenance. That is something. Now, single agent monotherapy. So you need to remember one thing. This is when you talk about IO in the first line, the maximum or the entire trial was driven by the benefit which was in those patients with the CPS of more than 20. In this trial, there were 40 to 50% patients who had a CPS of 40% or more. Now, when you look into the real literature or in India, it is hardly 10 to 30%. So 70% of the population, when you discuss about IO, it is less than 20%. And we all know the entire benefit of IO was driven by those with a CPS of more than 20. So in a Pembro mono, there was no improvement in intent to treat, definitely improvement in CPS 1 and more than 20. But again, this was driven by the patient who are having a CPS of more than 20. What about combination? Probably this is a way I use chemo with IO in most of my patients, not as a single agent, there was a quantum of benefit. But again, when you look into the subset of 1 to 19 or less than 1, and when you look into more than 20, the benefit was driven by those with a CPS of more than 20 in this population. So less than 20, always a questionable benefit. What about progression or hyperprogression? So let me first discuss a PFS, 2.3, 4.9, again, which was lesser than extreme. So one more important thing is rapidly progressing patient, probably not the best drug to give. 60% of the patient progressed in the first 5 months on pembro-meno, and there was no PFS benefit even with combining with chemo. So we have to be careful in a subset of patient where you are using this combination. The most important thing about hyperprogression, basically hyperprogression is 50% increase than the previous on the first analysis. Now, when you look into the pembro-mono, a very high degree of response rate of 23%, but when you look into CPS of less than 1, 50% had hyperprogression with CPS 20 at 31%. So when you give pembro, minimum 3 to 5 of your patient will have hyperprogression at the first interim analysis. And that is something which we have to be very careful about. The bottom line or the best part of it, they respond very well to chemo plus cetuximab if they have a hyperprogression. So that is a paradox. What about response rate? So although the response rate are good, 42.9 in the best subset of patients, CPS more than 20, against 57 overall in the TP extreme combination. But again, important thing is double the rate of progressive disease with pembro platinum with 5FU. So a drug which is good in a subset of patients, but needs to be careful about because of limited PFS, a limited response rate, and more importantly, a higher degree of hyperprogression. This was one paper which was published by Ikomatoulos. Again, the thing is around 20 to 30% of the patients at any point of time will have a hyperprogression when you give a combination of IO in the first line. And something we have all seen in our practice that this phenomenon of rapid increase rather than a decrease. The last part of my presentation is the results same in all the population. So what was in Asian subset? Is it important because whether we are Asians or we have to consider ourselves as Caucasian? The important thing is the site of the disease in Asian, that is more important, and probably that is where we want to extrapolate to what we are having in Indian population. What was the main site of disease in Asian, and how did the combination of IO work in the Asian population? So when you look into the Asian population, there was no overall survival benefit when pembro was combined with chemo, 1.03 hazard ratio, and 1 year it is 43.9 versus 46.9. So probably whether you have to question whether it is really good for our subset of patients or not. And this is my last slide. So what is different in Asian patient as compared to what was in the non-Asian or Western country was a higher higher number of primary location site which was a oral cavity. We all know that oral cavity by far 60 to 70% of all cancers in India are basically oral cavity and lip rather than hypopharynx and lower down. So probably some idea to say that probably whether it will work well in our population, we don't have a phase 3 data to support it. So if I have to summarize my presentation, we need to use all our active agents in a proper sequence to get the best overall survival. So anti-EGFR in the first line, probably 4 cycles of dosi with cisplatin with this, along with GCSF support, probably continuing our cetuximab, giving our IO in the second line. We have a very impressive data of India also, probably a low dose data probably. So we might sequence it in the second line, and at the end of the day, the most important thing is OS, and probably with this combination, you might get your maximum survival. I thank again organizers for a patient here.
Sir, thank you so very much first for completing in time, and as always is a great presentation. Dr. Rahul Sood, sir, any questions for Dr. Bharat? We have 1 minute. Anyone having questions for Dr. Bharat, sir? We have a minute to discuss.
So Dr. Bharat, crystal clear as always and fluent as it goes. But there is a question I definitely would like to ask you is, we've got such beautiful data of cetuximab. Are you tempted to try this combination like TP Extreme in the new adjuvant setting? That is, because many times our surgeons come to us saying, "Hey, we don't want to give our patients radiation. And would you like to combine a paclitaxel with cetuximab weekly, give a new adjuvant, and maybe take it forward? I'm trying to do it at my hospital.
Sir, even we are all, I am also doing it, and there are most of us might be doing it at some time or the other. Unfortunately, the data in a phase 3 setting, that is a problem where all the, why IO is supposed, because the data was a bigger and a phase 3. TP extreme was a randomized, but a phase 2 data. So the problem, what we know is cetuximab adds up to our chemotherapy because of synergism. We have a data of extreme, TP extreme, and when we talk about neoadjuvant, that is what we need, a better or a rapid response rate, and it adds up to the response. Unfortunately, probably we Indians should have to make a good data regarding it. The problem is that there is no purity of the data in a phase 3 setting with this now. So we use it, and I think so it is a good drug because it synergizes. There is a synergism with taxane, and it will add up to our response rate. Unfortunately, because of the paucity of data in the phase 3, probably we are reluctant to use it in our day-to-day practice.
Right. Thank you so much, Dr. Bharat. Thank you.
So,
Thanks for a kind
Dr. Bharat, sir, please allow us, if you can just, stop sharing your screen. Thank you so